Good morning, everybody. It's a real pleasure to be here and to see everybody. Let me get ourselves going. So before I start, I need to acknowledge that I have stolen a few pictures from the internet because my drawing skills are not very good. And so I'm going to thank them in advance. I'm sure I'm breaking a copyright thing, but hopefully they are feeling kind and generous today. So, happy Saturday. What a great way to spend a Saturday. Okay? And I'm hoping you've all got your coffee. I was chatting with somebody before we started. It's a little bit like school, isn't it? It's like, I'm guessing many of you maybe have not sat in a lecture for a long, long time. And so I'm assuming that we've got the ones at the front that are the keen beans that are always asking the questions. Hello, Jenny. And then we've got the ones at the back that are either going to talk all the way through or fall asleep or whatever, okay? And so that's good, okay? But I think it's important to say there's going to be a lot of information today, and so I think we all acknowledge that our brains are going to get scrambled a little bit, okay? And that's okay. Everybody here is very happy to chat and to discuss things, and you'll notice that I'll have to keep looking at my watch because I'll happily talk all day and talk all the way through everybody else's speeches, okay? So I'm going to keep looking at the watch to make sure I stay on time, but all of the docs are around all day and they're really happy to take questions and so on, as are all of the health care HealthTree team. And so I think it's also important to remember that unlike school, this can be quite emotional, and so that's okay too, all right? And we don't expect you to be able to sit through all of it. If you need to get up and go for a stretch, a wriggle, go to the restroom or whatever, please, none of us are going to take any offense for that. Okay, so what is my remit? My remit is really to kind of introduce myeloma a little bit and to talk about why every myeloma patient is different and why, as doctors and healthcare professionals, we need to make sure that we tailor our myeloma treatment to the individual patient. And this is just a slide. It's from the American Cancer Society. Really, the idea is to tell you that you're not alone. So myeloma is a rare cancer. It's only about 1% of all cancers that we see. So there's about 2 million new cancers a year in the US. And myeloma is about 1% of them, which is about 35,000 cases each year. So although it's rare, I'm sure you've discovered this if and when you tell people, people usually know of somebody else that might also have it. And theoretically, we think of it as a cancer of older people. Theoretically, the median age, so the average age of people who get myeloma is 70 years, okay? But you can see by this little graph that actually quite a few people get it much younger. And when you look around the room, is this me or? Oh, right. Okay. All right. Thanks, Leo. No problem. When you look around the room, you'll see that actually there are a number of people in the room that are much younger than that, and including Jenny when she was first diagnosed. And so we have to keep that in mind when we're thinking about how we treat myeloma. So a little bit of background, okay? So if you think about your normal bone marrow, so the job of your normal bone marrow is to make your blood, and it's also to make these things called plasma cells, which would fight infections. So we would make plasma cells if we need to fight, say, a pneumonia or something like that. And they make antibodies, which are the ones that kill off the cells. Now, in an adult, you make your bone marrow in the big bones in your body, so your hips, your legs, and your spine, and your shoulders, okay? Now, for myeloma, it's this plasma cell that goes wrong. And when this plasma cell goes wrong, it makes too many proteins. So it makes lots and lots of antibodies. But rather than those antibodies being able to kill off an infection, they are just hanging around doing nothing apart from causing damage to the body. And so we call these antibodies in the tests that we do a monoclonal protein or an M protein, or there's also this thing called the light chain or the serum-free light chain. And those are the two things that, yes, cause the damage, but also that we use to monitor patients as they go through their treatment. And one of the or amongst the many problems that patients have is problems with their bones. And if you think about it, if any of you have presented with bony problems, it's about 70% of patients that have problems with their bones. It's in those bones I talked about, so the spine, the hips, the top of the arms. I can say, I'm not sure my pointer's going to work very well here, but if you look at this X-ray, you can see there's kind of a black bit in the middle there. That's kind of a hole, and what can happen is that's thinning away at the bones, and it can cause a fracture. Or this is an MRI of somebody's back, okay? And if you look very closely, there's a kind of white blob there, okay? And that's a bit of myeloma in the back, and it causes collapse of the vertebrae. And so some people find that they either lose a little bit of height or they find that they become a little bit hunched over because the myeloma is eating away at the bones. And so we can use X-rays to show this, we can use MRI, or some of you may have had a PET scan, which is this one here, okay? This bit's supposed to be black. This is the brain, so we worry if that bit doesn't come out black. And this is the heart. But you can see there's lots of other little black bits, which is where the myeloma is being active. So when we see a newly diagnosed patient, we think of bone disease. Your bones need calcium, and so the calcium can sometimes be high if the bones are breaking down. And that calcium, as well as the protein that the cells are making, can damage the kidneys. The other thing that can happen is that if you imagine the bone in your bone marrow, like I said to begin with, is meant to make all of these normal cells that either make your hemoglobin, that give you your energy, or make your platelets that stop you bruising and bleeding. And so if you're not making those things, then you can have other problems. And if the myeloma cells are in the bone crowding everything out, we can get issues and problems from that. And many patients, when they look back, will kind of think, oh, you know, I did have a lot of infections before I was diagnosed. I had shingles and this kind of thing. And so those are all the kind of problems and issues that we think about when a new patient is diagnosed. The important bit is, though, that not every patient gets every problem. And so I'm sure some of you may have had the bone problems and so may have kind of either gone to your PCP or ended up via an orthopedic surgeon because you maybe had a fracture. Whereas other patients, maybe their bones are great, but they actually have problems with their kidneys. And this causes a bit of a problem for doctors. And this is a kind of a timeline study, okay? It's some UK data. But essentially, this is when the patient was actually diagnosed, okay? And then this is the number of days it took for the patient before they got diagnosed, okay? And essentially what we're saying is that it can be nearly a year that patients have been having problems going to see doctors and saying, oh, you know, I've got a backache, what's going on, okay? And it can sometimes be a year before those patients make it to having a diagnosis. Depending on what the problem is, if it's the kidneys, then that one tends to get spotted a little bit quicker and people tend to get the diagnosis quicker. And I guess one of the questions is, why is that? And to some extent, unfortunately for us, you can imagine how many people the average PCP, the average general practitioner, sees with bone pain every week, okay, compared to those patients that actually have multiple myeloma. And so HealthTree and many others are doing a lot of work reminding doctors to think about multiple myeloma when they first see patients. Okay, so what happens? This is our kind of current approach to myeloma. And I don't know if there's anybody in the room at the moment with this condition called Muggus or smoldering myeloma. That's a kind of condition that we monitor. It's where patients, we can see problems in the blood, but they're not having any clinical problems. But once myeloma becomes active and starts giving clinical problems, then we give some treatment, okay? And the way this graph is worked is that this is that marker I was talking about that we can see in the blood. So if that marker gets very high, okay, then we start treatment. The myeloma goes quiet, it stays quiet, hopefully for a long time, but we continue to monitor that marker. If it goes back up again and starts causing problems, we start treatment again, it comes back down, and so on and so forth. However, what I want to say is that over the last 20, 25 years, we have made such remarkable progress, okay, through the researchers and through initiatives like the foundation. And now, actually, myeloma is one of the cancers with the biggest improvement in survival, okay, but also the largest number of drugs that have been introduced. And the treatment that we used to use maybe 5 years ago or 10 years ago is incredibly different to the treatment that we use now. And as I go through the rest of my talk, there's going to be a kind of a theme, which is, as patients, it's really important that you, I was going to say, there used to be somebody we worked with that said knowledge is power, okay? But as Jenny said, really making sure that you advocate for yourself and that you kind of keep up to date with the information, and if necessary, see a myeloma expert, because this is just changing all of the time. You don't need to move your care to the myeloma expert, but just maybe keep in touch with them every now and again so that you know that you're getting the latest treatment and the latest information, because it has changed dramatically. And this is where we're hoping we're going to be, okay? We're hoping that we're going to be that when we see a patient's disease is active, that we give one treatment, okay, that we get rid of it, and that the patient has a normal length of life, okay? And as you go through the day, you're going to hear from some of my colleagues about some of these new treatments that we're currently using in relapse disease, but that seem to be so incredibly effective. We're looking forward to having them for newly diagnosed patients, because we truly believe that we can get to this place. Okay, so what are our current treatment goals? So I think number one, which is the most important one, is to make sure that patients have a good quality of life. And that kind of comes in two bits, okay? One is trying to turn the myeloma off and make sure that we can not have the myeloma cause any problems. So that would be, for instance, if the patient's been having fractures and weak bones, we need to make sure that those bones become strong. The second one is to try and minimize our treatment side effects, okay? Now, kind of, I don't know, maybe 10 or 15 years ago, we didn't have many treatment options. And so, yes, we'd listen to patients telling us about their side effects, okay? And we'd be like, yeah, okay, unfortunately we can't do anything else, so you're going to have to carry on and put up with it. Whereas now we've learned such a lot about, yes, we can maybe change the drug to something else, but we can also maybe drop the dose or change the frequency to really try and get those side effects to the lowest. We know that having patients respond to therapy is really important, and also the lower the myeloma goes, the better. And we know that if we can do that, we decrease the chances of the myeloma coming back. And clearly, I think for everybody, we were certainly aiming for a good survival. Okay. Now, how we achieve this is actually different for every patient. Okay, because not all myelomas are the same. Okay, as I already said, when you chat with each other, and that's the importance of coming to one of these meetings, when you chat with people over coffee and lunch, you'll find that people presented differently, okay? People also have different clinical needs. They have different thoughts about kind of what their goals of treatment is and what they want to achieve. They have different responses to therapy. Some patients respond very well to one treatment, other patients respond well to a different one. And side effects, okay? We'll learn a little bit about some of the newer treatments, and they come with some weird side effects, which some patients don't get any of, and other patients get them really severely, and they're like, not having that one again, okay? And so we have to remember that when we're thinking about a patient, and that's one of the important things about treating myeloma, is remembering that everybody is different. So what's step one from a doctor's perspective? That's really to collect as much information as possible. And I always use the analogy that if I'm going on a road trip, okay, I'm going to look at the map, decide where I'm heading to, and decide the right direction. I might change my mind along the way and move things a little bit, but I'm going to make sure I've got everything, all my ducks in a row before I start. And so that's making sure that you know the patient's medical history, you've examined them and you know what's going on, but also you know their blood counts, what their kidneys are doing, what their myeloma markers are doing. And that's both in the blood and the urine. The dreaded bone marrow, okay? Unfortunately, at the moment, we don't have a way of looking at those myeloma cells in as much detail as we need to without doing the bone marrow. There's lots of work going on trying to get it that we can do it from the blood. We're not quite there yet. Imaging, we've already seen some pictures, okay? But also we have to remember patients often have other things going on. Maybe they've had heart attacks, blood pressure, diabetes, asthma. So we also need to make sure that we know about that so we can put all of it together to make sure we've got the best plan. So how do we decide on the most appropriate treatment? So I think there's a number of ways of deciding what a good treatment outcome is, okay? Clearly, what we call treatment response, okay? And you'll hear talks today talking about response rates, okay? And so that's just the number of people who have responded, okay? We can talk about what we call progression-free survival. So that's how long a particular treatment lasts for, okay? And then I think we all know what overall survival is, okay? But in order to kind of know what factors are important, we actually have to study a lot of patients, and that's what we've have been doing over many, many years. So many people may have been in clinical trials where we've given treatment A and treatment B. We study those patients and we figure out who does well and who doesn't. And then the other way is we use registries where we put lots of patients' data together and then again figure out who does well. The key to it though is that we have to remember we have to compare like patients. So as I said, many patients are very different, bone problems, kidney problems, age 95, age 35. And a bit like the old thing, you have to compare apples with apples. You shouldn't do apples, oranges, and bananas. And so it's really important when we do that. But when we do that, we think of kind of a number of different things to help us decide the most appropriate treatment. And I've divided them into two groups, okay? One is patient factors, and then the other is myeloma factors or disease factors. So when we're thinking of patient factors, we generally try to, although we're taught not to put patients into boxes, we generally try to think of patients in 4 boxes, okay? We've got the younger fit patient, okay, where we can potentially throw anything at them and they're going to bounce back. A little bit like that 5-year-old that picks up the flu one day, looks as if they look awful, and the next day they're charging around, okay? We've got older patients, but who are still very fit and strong, okay? We've then got patients that are maybe frail or have other problems, okay? And then we've got people who are very frail. And you'll notice I'm not putting an age on any of this. We used to have ages on everything, okay? But I think we've actually realized now that what we call your chronological age, so whether you're 40 or 70, is nothing like your biological age, okay? And so we kind of tend not to do that anymore. But we do a kind of, judge, I guess, if that's the right expression, about what we call patients' performance status or activities of daily living. So are they up and about, cycling, doing whatever? Are they up and about managing to work, but are not coping so well doing the cleaning, maybe? Do they have problems and they're in bed for most of the day? And so we do a little bit of that. And then, as I say, we think about other things as well. So those are the patient kind of things we're looking at. But then we also want to know something about the myeloma itself. So the actual amount of myeloma, where it is. Sometimes patients' myeloma can present with lumps and bumps. Sometimes it can present so we can see it in the blood. Has it affected the kidneys? Has it affected the liver? And then a little bit about the way those myeloma cells grow. So I'm going to get a bit technical for a few moments. Those of you who hated biology at school, by all means, switch off for a few minutes, okay? And then I'll give you the sign when we've finished, okay? And you can switch back on again. So the reason this bit is important is that you'll often hear people talking about patients who have high-risk disease. And that is based on a number of factors that we're going to talk about. But one of the things it's based on is genetics. Now, this is not family genetics, so it's not whether it, passing things down from parent to child or anything. This is just literally the genetics of that myeloma cell, that cancer cell. So within the cell, all of your genetic code is packaged into this thing called the chromosome, okay? Remember, ladies have 2 X chromosomes, men have a Y, okay? That's how we're differentiated on a kind of genetic sex-wise. But there's also 22 other pairs of chromosomes, okay? And then within that bigger package, we have your DNA, which is the genetic code. And it's that genetic code that actually then makes the proteins, and it's those proteins which are the building block of your cells. And so the idea here is that there's problems with the chromosomes and the genetic code, and that means that the building blocks of the cell are not made correctly, and so the cells go crazy, grow too much, don't die, etc. And so we do know quite a lot about the abnormalities that happen in that genetic code. And this is where I said it gets a bit complicated. And there's 3 different kinds of abnormalities that can happen. You can have changes in the chromosome number. So again, just in the cancer cell, but rather than having 46 chromosomes, you can maybe have 42, or you can maybe have 56, okay? You can have changes in the chromosome structure. So each chromosome actually has a number, and you can have it that a bit of one chromosome flips over and joins a bit of another chromosome. Or you can have changes in the actual code itself, okay? And as I say, all of these different things mean the building blocks of the cell are wrong, so the cell grows too much. And so some of you will have heard, I'm guessing, your doctors talking about some of these changes. So the changes in the copy number, ones we often talk about is what we call trisomy or gains, okay? So those are the 3, 11, 15, okay? We sometimes also call that hyperdiploidy. We can sometimes see that patients might lose 1 of chromosome 13, or the important one is one of losing a little bit of chromosome 17, okay? And of the bottom pictures, okay, I don't know if you can see this very well. I know it's a bit small, but you can, oops, go back one. Oh, wrong way, hang on. Now I'm, okay. You should just have 2 of each of these, okay? So you can see that there's 2 of those, there's 2 of those. But you can see that in some places, there's 3 of them, okay? Each one of these lines is a chromosome. And so that patient has too many chromosomes. Whereas in this example, okay, they've colored the different chromosomes to make it a bit easier. But you can see here, this is chromosome 4, and oops, chromosome 4 has got a yellow bit at the end that should actually be over here on chromosome 1, okay? And that happens in a few places, so you can see that chromosome 7 here has got a pink bit on it, and that should actually be over here, okay? So we can do all of these things and find out the differences of the myeloma code, and we know that this is important because some patients who have problems with their code, their myeloma cells will grow particularly fast. Now, one of the issues about this is that how we define high risk really depends a little bit on the technologies you use, and this is changing day after day after day, okay, getting much more sophisticated. But also our therapies. So what we used to think wouldn't respond to treatment, many of the newer treatments can respond, okay? And I think another important thing is just having one lesion doesn't necessarily mean you're high risk. So I think it's important that when we talk about high risk, that you discuss it with an expert. I will often see, it's one of my passionate areas, okay, and Dr. Rahmani is passionate about it too. I'll often see patients who come to me saying they've got high risk, and then when we look at it, actually it isn't high risk. And we'll come back to why that's important in a minute, okay? But essentially, there was a big meeting in September, so a few weeks ago, okay, where we introduced the new criteria for high risk. There's been lots of refining it, and I don't want to go into the details now, but these are what we call high risk now, okay, because we've refined it. And that will actually mean that many patients who thought they were high risk are not high risk, but also many patients who maybe didn't think they were high risk are high risk. And the big change, okay, for those that are kind of into this kind of thing, is the patients with a 414, okay? We always thought that patients who had the genetic abnormality of a 414, that's where a bit of 4 sticks onto 14 and a bit of 14 sticks onto 4, performed badly. And now we've discovered that actually half of them don't. Half of them actually can perform very well. It's just those patients that have another problem as well. And so there's some finer detail, and I'm happy to discuss this with anybody that wants to afterwards. But I think the key thing is, why do we want to, let me go back here, why do we want to know about risk? If you're a patient, and I'm a doctor, I don't want to be sitting there saying, hey, okay, I'm going to treat you, and I think I'm looking that you're going to be alive in 20 years' time, okay? And then it all goes pear-shaped, and actually you don't respond to your first treatment, and so on and so forth. And so I think that we really, as doctors, we're not very good at this, but if we don't think a patient's going to be, do so well, for me personally, I think it's important that we tell them. I clearly don't want them to go and spend all of their money and take me on my kind of word for it, but I think it's important that the patient knows kind of where we're expecting things to end up. Okay. So as I say, it gets more complicated because there's lots of new things coming on, and I don't intend to have this up for long, but just to say there's lots of new genetic things going on. We're learning more about what it means if you've got patches of myeloma outside of the bone, if you've got myeloma cells in the blood. We're learning about what happens if you're frail, what happens if you've got problems with the kidneys, what does happen if you don't respond to your first treatment, is that, and so on. And then with all of these new therapies coming on, we've always concentrated on the myeloma cell itself. We've kind of always ignored the rest of those cells in the bone marrow, so those ones that kind of, I guess, provide the soil, okay? So, what happens if those cells that provide the soil and the structure, if they go wrong, what's their role? And what happens to the immune system? Is there anything we can do there? And with many of our new treatments, we're actually concentrating not only on the myeloma cell, but these other cells as well. So I've got 5 minutes. I told you I could talk forever. Hot topic for research, lots of meetings going on. And I think we've already said this, that patients need to know, but also for all patients, we want to get their myeloma down as low as we can, but we want to do that fine-tuning and make sure that we get the treatment right for them. So what do we do now? If you're younger and fitter, okay, we're going to give some treatment to get the myeloma down, okay? We then may do what we call a transplant, which is where you have cells, your own cells giving back to you. And we're going to hear later that there's some changes there as well, because we may do this thing called a CAR T. Once the myeloma's down, we're then going to make sure it stays down by giving some consolidation and maintenance. If you're older or maybe not so fit, we're going to take a similar approach, but we may not do that transplant bit in the middle because that can be quite toxic. Those are the basic principles. The actual components of what we put in there differ between patients, okay? But the principles are the same. And you'll see something similar when you chat with your peers today. The fact that some patients may be on one drug for maintenance, other patients may be on 2 drugs, and it needs to be fine-tuned for the patient. So this is a picture that Hervé made a number of years ago, and essentially what I wanted to say was that as time has gone by, in the 1900s, we used rhubarb to treat patients, okay? Now we've got much more sophisticated, and certainly this was a graph that Hervé made a couple of years ago. It's now completely changed, and if she was to make this graph again, she would actually do it slightly differently. So the way we do the treatment is that we need logical combinations, and we've got different groups of drugs. Okay, so those are the columns. They all work in slightly different ways, and then we pick one of the drugs from each of the groups and use it like a jigsaw. So, for instance, some patients, when they're first diagnosed, may have 4 drugs in their regimen. They may have a steroid, they may have an antibody, which is called either daratumumab or isatuximab. They may have an IMiD, which is called Revlimid, or they may have a proteasome inhibitor, which can be bortezomib or carfilzomib. And depending, they'll have those, whereas others, maybe if they have problems with their kidneys, actually using some of those other drugs may not be the best approach, and so we'll change the regimen to make sure that it matches the patient. But we can do all sorts of different things with those drugs and use them, one from each group, putting them together and combining them so that they match the patient. So I think I'm kind of coming to a close now. Essentially, I'm saying that we should be personalizing therapy, okay? We need to do it, I'm going to start from the middle bit, we need to do it based on the patient's disease biology. Do they have high risk? Do we need to change anything? Do we need to do anything different? We need to think about what problems the patient has. Are the kidneys a problem? Is the heart a problem? Do they have neuropathy? And we need to make sure that the patient has a good response to treatment, and if they don't, we need to be on our toes and change things. We've always had patient choice in this list, and the truth be known, up until recently, we haven't really taken patient choice into consideration because we haven't had a lot of different drugs. Whereas now we do. We have some that get given as an infusion, some that get given as a shot, some that get given as a tablet. And we've discovered that not all patients like the same kind of approach. Some patients would prefer tablets, and so they don't have to come to the hospital very often. Other patients prefer to come to the hospital. And so we are now in a position where we can do these different changes. And essentially, as a doc, we need to be smart and clever about how we use our drugs to make sure that we're getting the best for our patients. Just in closing, we need to forget that it's not just the chemo that's important, okay? Pain control, so important. The number of patients that tell me, oh, I don't want to take the pain meds, doc, because I don't want to get addicted, okay? I get that, okay? Usually for patients who have pain, if they're taking their meds properly, they're not going to get addicted. And from my perspective, what I don't want is for a patient to maybe be having pain in their chest and taking little breaths, whereas if they had the pain meds, they'd then be able to take big breaths and their chances of them getting a chest infection would be much less, okay? Or indeed, if they've got back pain and therefore they're not moving around so much, then what happens is then the muscles in the back don't get used and we end up getting into a worse position, okay? So pain control can be conventional, okay? So yes, patches, tablets, but also acupuncture, reflexology, all of these things now have been shown to be beneficial and are usually available at many of the cancer centres. Exercise, so important. Not saying run a marathon, okay, but just moving, making sure that you're keeping the muscles strong to protect the bones. We all talk about bone health. We usually give many different tablets or infusions for that. Reduce infection risk, okay? We always give you extra kind of tablets or vaccinations and so on. They're really important. Drinking lots of fluid. And then I think Hervé is going to be talking. I can't see her. I hope she's here. Yes, I can. There we go. Hervé's going to be talking about diet and the importance of that following me. And so I think that's really good, okay? And then my last one is the last thing any of us want to happen is that you forget about your annual physicals and your routine screening, okay? I don't want that I can sit there and say, yay, myeloma's under control, and then we've forgotten to do a colonoscopy or we've forgotten to do a mammogram or something. So they are really, really key. Okay, so in conclusion, I want to say that everybody's myeloma is different. It presents differently. It responds to treatment differently. And so making sure from a doctor's perspective, but also a patient's perspective, we need to make sure we've got all of the information, and then we can plan which drugs, how often, what doses. And that has to be a continuing discussion every time you go to clinic. Is the patient on the right dose? Have we got it right? Because to some extent, it sounds crazy, but if the patient ain't on the medicine, it's not going to work, okay? So we have to get that going well. And then just to say, lots of research going on so that we can improve outcomes. So thank you very much for your attention. I hope your brain...